Well, hello, everyone, and thank you for attending our COVID-19 webinar follow-up series. My name is Holly Foxworth. I'm a registered nurse here at Axiom Medical, and I'm also joined by Axiom's Chief Medical Officer, Dr. Scott Cherry, and Emergency and Critical Care Physician with Methodist Hospital, Dr. Rezvankhoo. I'm so sorry, I just murder your name every time I say it. It's horrible. My apologies. Well, welcome to the live stream, guys. We appreciate you joining us today.
Thank you.
Yeah,
happy to be here.
Perfect. Before we get started with this, I know we have a lot of questions to go through, but I did want to just let you both introduce yourselves and just kind of tell us a little bit about your background before we get started. Dr. Cherry, you want to start?
Yeah, hi, good afternoon, everyone. Thanks for joining. I'm Scott Cherry. I am a preventive medicine and occupational medicine physician. I've been supporting military, industrial, or corporate functions for the past 10 years, and I look forward to continuing these webinar series with you.
Great, thank you.
Hi, how are you? My name is Kabir Rezvankhoo. I'm ER and critical care doctor here in Houston Methodist, and that's pretty much it.
All right, perfect. Well, thank you again. We appreciate you being here, but you guys did such a great job this last week whenever we had the webinar on the Twindemic, really bringing attention to many of those presenting symptoms that may be very similar for both COVID-19 and the flu. You know, whenever we talk about the general public, I think that naturally we're seeing, you know, an uptick yet again with additional questions of what's going on, you know, what are we facing, et cetera. And so as we see that uptick along with the flu season, and then you add into that also the additional travel that will come up with the approaching holidays, it's more important than ever that we all educate everyone and that everybody does their own part. So as I mentioned, we do have a lot of questions that were submitted here, but I did want to get your thoughts on the messaging here that the CDC had put out yesterday in terms of the close contact. Dr. Cherry, do you have anything that you'd maybe want to kind of go through that a little bit further? It seemed like that there was some changes there in terms of you know, I think previously we were thinking it was 6 feet and the 15-minute duration, but it looks like they've made some changes there.
Yeah, so the CDC has given guidance about how do you contact trace those that are exposed or potentially exposed. Originally, they were saying within 6 feet. They didn't really disclose a time period early on, and so we had made an internal decision to go with 10 minutes, and then eventually the CDC came out with a 15-minute kind of criteria, and those are guidelines. It's trying to kind of quantify risk with respect to exposure, but there's many more other components of a risk assessment besides distance and time. For instance, was the person actively symptomatic? Were you 1 feet away versus 6 feet away? Were you 6 or 10 hours with each other versus 15 minutes? And this new guidance talks about a collective 15 minutes over the course of a day or so, whereas I think the previous guidance lent itself to saying that, you know, an exposure had to be 15 minutes to be considered risky. So if you had a 14-minute exposure in the morning and then a 14-minute exposure in the evening, it technically doesn't qualify. You know, as we've been supporting our clients with this, we've been approaching it as kind of a behavioral-based assessment. So obviously, if you met the specific criteria, we would consider that a close contact or a contact trace. But we also look at behaviors, especially with travel, were people wearing masks? Again, was someone symptomatic? Were people in the, you know, in your close contact not wearing masks? And, you know, were you actively talking or yelling versus just sitting quietly breathing? And so really there's a continuum of risk. And I think this CDC change right now is just a reflection of more nuance around risk. So again, just looking at the time spent could be collective. So it could be throughout the day versus a one-time period in general.
Great. And were there any changes then in terms of the guidance for precautions? They didn't address that in the guidance for the exposure, correct?
Correct.
Yeah, perfect.
Yeah, and so we use our expertise to help really provide a much more nuanced and sophisticated risk assessment for contact tracing.
Good deal. All right, excellent. Well, thank you for that clarification. I know that we've had several questions that have came in from that. Sometimes there's some mixed messaging that comes that's associated sometimes. So we appreciate the clarification there, Dr. Sherry. Well, proceeding on to the webinar questions, as I mentioned, we had a lot that were submitted. So this definitely was a topic that everybody wanted new information about. But the first, it came from Jennifer, and she was asking if you have a positive influenza diagnosis, would that negate the concern for COVID-19? And would an employee still be instructed to quarantine since the symptoms could be very similar?
I can look at it from our perspective first. We know that there is evidence of co-infection, and so that does exist. So it should be in the back of your mind. My feeling is that co-infection is probably less common than just I guess a singular infection with either COVID or flu. But again, that is in the back of our mind, especially when we are preparing for flu and trying to either determine if which of the infectious diseases are causing the illness, because that really changes the return to work guidelines. And as I've thought with Dr. Rezvankhoo, his experience in the ICU, I believe you've taken care of patients with both, haven't you? And so I'm curious if it's a common occurrence outside the ICU, or if it's perhaps your patient population might be at higher risk because they're more susceptible or in that vulnerable population. But do you have any thoughts along that?
Yeah, so I definitely think that co-infection does exist, and I think they're probably underreported. If you remember in March, based on some of the guidelines that are coming out, what we were doing, at least in probably across the whole country, was that if you were influenza A or influenza B, then you wouldn't get COVID testing. Now, this was probably because we didn't have testing readily available. And so there was a backlog of testing ability. And so, but when we were doing testing for COVID-19, we definitely saw co-infection rates. And so in my mind, we are in the middle of a pandemic. And I would, if I had just one if I just had one choice of a test to take, I would just take the COVID-19 test, because it is far more contagious than influenza, and because of that, it would essentially have a huge impact on the workforce. The caveat to that would be that if everyone does wear masks, you probably are not going to see that much influenza.
Yeah.
So in my mind, COVID testing is where everything needs to be done.
Good points. Yeah, that leads us on actually to the next question. Pam had asked us, did we think that there would be a lighter outbreak of the flu this season, since people are following some of those COVID safety precautions, the hand washing, the wearing masks, social distancing, et cetera. So do you anticipate that there could be an impact there, since they are already using some of these measures?
Well, I mean, there was a nice study that was done recently looking at Australia, and they're in the Southern Hemisphere, so they're probably going through their winter earlier on, and there was a decreased incidence of influenza. Mm-hmm. But this all goes back to human behavior. And so, definitely when I'm around town, I definitely see people wearing masks, doing their best. And I think if you have that kind of culture, you're going to definitely see a decrease in influenza, in my mind.
Great. Okay. The next question that we had was from Deborah, and she was wanting to know whether a COVID-19 test would show positive or negative if their employee was asymptomatic.
You know, there was a study recently released that showed really the false negative rate from time from symptoms. And I believe the false negative rate for asymptomatic was very, very high. And as you became symptomatic, that false negative rate dropped precipitously. And something that we've always incorporated for our clients that have a testing strategy in addition to the syndromic surveillance that we provide is understanding the weaknesses of testing when it comes to the timing of tests to symptoms. So that's kind of been my view from a population health perspective. What have you seen, Dr. Rezvankhoo, in the ICU?
Right. Well, I can talk about the ER in this regard.
Oh,
I mean,
yeah.
In terms of, we don't offer testing usually to those that are asymptomatic for that exact reason. You know, with symptoms to start from inoculation time, it could be 5 days, let's say 5 to 6 days on average, where people start to develop symptoms. Maybe what's happening when we describe people as being asymptomatic, in my mind, I probably would imagine a person who's just feeling a little bit fatigued, but they don't actually have a full-on fever, cough, or myalgias, but they just feel tired, let's just say. Maybe those are the asymptomatic people that we would probably identify as being asymptomatic. But I think, you know, once you start showing some form of symptoms, that's the best time to test.
Right.
Yeah.
So let me ask you this: are you guys then performing both the flu and COVID testing? Do you do both of whatever you're administering?
When we come in, when anyone comes in the hospital, we automatically, it could be something unrelated. We automatically always do COVID-19 testing, just so that we know they're negative for the purposes of knowing the level of isolation that person's going to need, and also to protect the healthcare workers that are working. And let's say if that person's needing an operation, they can go to the OR knowing that that person is COVID negative. And so the whole protocol changes because of it. But if someone came in with a cough and cold or symptoms that are influenza-like, they're going to get both tests.
Right. Okay. Good point. The next one that came was from Kathy, I believe, and it seems like we've seen this one before, but let's address it one more time. Kathy was asking if there was any factual proof that the blue surgical masks are better than wearing a cloth facial covering.
Dr. Rezvankhoo?
Yeah, sure. I mean, there's absolutely factual proof that surgical masks are better than cloth masks. In fact, I'll tell you, I have a patient right now that essentially was wearing a cloth mask and then contracted COVID-19, working in the cubicle next to another individual. So surgical masks are better. They're a 3-ply. There have been some studies done, you know, from more of a quality control type studies that have been done that looked at the ability of these surgical masks to minimize aerosolized droplets, let's say, of the individual. But the mask really is to protect everyone else, right? Not necessarily going to protect you, albeit that surgical mask is all you really need if you're walking into someone with influenza or even with COVID-19, that and the face shield. So we don't use cloth masks in the hospital. So, I mean, a lot of that is common sense.
Yeah. You know, I can add a little bit to this. What was very interesting at the early part of this pandemic was very interesting to me, coming from OSHA and CDC. Once there was a decision for use of masks within the workplace and in the general public, and I would specifically talk about the workplace, there was guidance that to make your own mask, to really not have any super consistent quality of the type of mask. And I know that this was early on when there was a concern about the logistics of having adequate personal protective equipment for especially healthcare workers, but then again, to the rest of the country. And so I have never seen that in the occupational medicine realm, where if an employer is required to have personal protective equipment in the workplace, the employer usually has to provide it, and it has to be some type of standard. I think now we've seen at least the CDC provide guidance that a 2-ply face covering is really a minimum. And we get asked a lot about gaiters, which are kind of it's kind of like a scarf that pulls over, and those are usually single ply, so it's less protective. And, you know, it's really good to hear your comments, Dr. Rezvankhoo, about actually 3-ply, you know. So, and again, I remember our conversation last week where you're engaging with the majority of your patient care with that level of personal protective equipment, and you feel very comfortable doing that. So that's really good to see practically.
Yeah. Well, and two, I was noticing that on the news last night. I think they were showing that there was a study there that had looked at how frequently, for those that are using some of these facial coverings, that, you know, they weren't washing them, or they were using them multiple times. And even some were making reference to reusing some of the disposables. So do you want to maybe outline what the expectation is, what they need to do in terms of when one needs to be washed or when it needs to be disposed of?
I can talk about like what I've been doing since March. So we use 2 different types of masks. There's the regular surgical masks, which are usually 3-ply masks, which we dispose after 24 hours. So we wear it for a period of 24 hours and then we dispose of it. Do you have to do that? No, you can actually recycle them. For N95s, what we're doing is we've developed a sort of process where we can recycle them. And there have been some nice literature that looks at low-level heat as a way to disinfect these masks, and also using like blue light or UV light to help disinfect these masks. And so there are different procedures out there where you can actually disinfect these masks and reuse them. And normally we will use an N95 mask, I believe, for between 5 to 10 cycles before we return them. Dispose of them. So you can really make these masks last a long time, especially if you're in a low risk environment. I think if you're outside the hospital, you're low risk. And if we're recycling masks, there's no reason why the community can't do that.
Right. Dr. Sherry, I think that the guidance that we provided for some of the productions was if you were using the cloth mask, that you wash those daily. Isn't that correct?
Correct. Yes.
Yeah. Okay. All right. Good deal. All right. Well, the next one came from Deborah, and she was asking what additional precautions, so this would be anything outside of already washing your hands, wearing masks, social distancing, etc., would be recommended within a school setting. And then the second piece of that was she was also wanting to know whether an isolation room would be recommended for potential COVID positive students. So I would assume that she's making reference to, you know, someone that presents maybe once they've gotten to school and had a symptom that was consistent with that.
Sure. You want me to answer that, Scott?
That'd be great. Thanks.
Yeah. So if you look at the literature, at least in public school systems or across the country, or school systems across the country, those that are ages 10 and less have a far less transmissibility of the COVID-19 virus compared to those that are over the age of 10. So that alone is an important variable. So if you're in elementary school, you're dealing with anyone that's 4th grade and below or 5th grade and below, the risk of them infecting others is far less. That's just because their droplets don't travel as far as adults. And so once you're in middle school and high school, that's where the exposure risk is similar to what we're seeing in the community. And that's where the CDC guidelines really, I would say you have to stay close to that. Now, you know, whether it's so we use these terms like an isolation room, right, in the healthcare setting, because we need to isolate individuals and put them in specific rooms so that we as healthcare workers can know what precautions we need to take and to walk into the room so that we don't transmit this infection to our other patients. So in the community setting, do you really need to have a dedicated room to send someone there? You know, probably not, but you can, from like a hospital level, but, you know, it is a smart idea to, you know, distance that patient or that person away from the rest of the class. And so whether it's going to be sending them to the nurse's room or nurse's office and having them sit there until their parents pick up the child, that's fine.
What about the first piece of the question that she'd ask about any other recommendations about precautions? What are your thoughts about, you know, smaller groups maybe of the students being there together, or some of the changing up some of their schedules so maybe they're not in hallways congregating as much? Any thoughts there?
Right. So I think, you know, keeping kids 6 feet apart is ideal. Spacing out the desks, wearing face covers, hand hygiene is very important. And outside of that, I don't imagine, and there's any other thing that we could do to ensure the minimize the risk of spreading of the virus.
Right. Okay. Let's see. Oh, this is a good one. Naturally, I love it. I'm probably a little biased, obviously, towards our Check Into Work app. But Daisy had asked if there was workplace technology that would be recommended for medically screening employees with questions before they enter a building.
Yeah, I can take that one. And so, yeah, obviously, here at Axiom, we are slightly biased because we have created that tool. And so we've always talked about a paradigm shift of, you know, before COVID, people were probably coming into work or school when they've been ill, and they just are very goal oriented or focused, or it's part of the culture, or maybe they felt like they didn't feel supported to take a sick day. Now with COVID, with all the implications of threatening continuity of operations in business, in schools, in community settings, really, I think now's the time where we need to shift our culture to not, for our own self and for our family and for the public, to push this shift of not coming into the public, not coming into work, not coming into school if you're ill. And as we've thought through it, maybe a great culture change tool is actually every day, before you're going to enter into your getting ready for work or school, is, you know, answer a few questions about how am I feeling. I think you had some great comments there, Kabir, about are the asymptomatics just really occult pre-symptomatics or mildly symptomatic? And we see that in our large scale screening process where people are just talking about very minor symptoms at first, but if we keep them out of work for at least a few days to see if those symptoms continue to worsen or not, it's been helpful. But getting back to like we're all on our cell phones, and I think there's a lot of studies about how that's changed our behavior in many ways, potentially negative, but I think this would be a positive behavioral change where we're assessing ourselves before we're going to do any type of group activity, whether it's work, school. Dr. Kabir and I actually ride bikes together, so I hope he screens himself before I'm chugging behind him. So, yeah.
Yeah. So whenever they are going through the questions, then give us an example of the types of questions that might be included in a screening tool.
Well, historically, we were kind of modeling some of the CDC guidance with regard to fever, and then other influenza-like illnesses like body aches, fatigue, chills, cough. But then we would also add in other components like when geography was more germane to a risk assessment, coming obviously from Asia or Europe early on, and then when there was specific hotspots in the US. We've changed our view on travel to a degree because now COVID risk is more homogeneous across all of the geographies. relatively speaking, to more of a behavioral-based assessment. And then also one of the largest risks for transmission is household contacts. So that's usually specifically called out is, you know, you may be feeling fine, but like, oh, everyone in my house is feeling terrible. And so that's probably one of the biggest risks for transmission is household contacts, because you're going to spend a significant amount of time with them, you know.
Yeah, yeah. Well, we just had a comment, several comments that actually came in on the chat while we were having this discussion. One was from Thrive Academy that was saying that they actually use the app and that it's been helping to ensure the safety of the students and faculty. So thank you for that comment. But revisiting were the other subjects that we'd addressed, there was a question of whenever you guys were referring to disinfecting your N95s, are you doing that in the hospital or is that outsourced to a service provider?
No, it happens in hospital. So there's a process that we essentially, at the end of the day, give our N95s. It has our names written on it, and we have like a check for the cycle of, you know, if I'm using it again and now I'm returning it, then I put another like a mark on it, so I'll know what cycle of use, and then within 24 hours it gets returned to us. Before we even implemented that, what many people were doing was essentially maybe taking out 7 or 8 N95 masks and just numbering them 1 through 8. And then, you know, on day 1, I'll use 1. On day 2, I'll use 2. And then day 1, that one that I used yesterday, I would essentially leave mine in the back in my trunk of my car where it's kind of hot. Mm-hmm. And I wouldn't go back and use that until like 10 days later. And so, in that regards, you know, if you look at how long the COVID-19 virus can actually live on surfaces, maybe it's 8 to 10 days, sometimes less. But if you put it in a hot environment and leave it alone for 10 days, the likelihood of that virus actually surviving on that surface is very low. And so that's what I was doing in March. I essentially had 10 masks. I would count them, and I would, you know, use it that day. At the end of the day, I would take it out and put it somewhere else. And what I would do is I would use my surgical mask on top of my N95, not so much to get the extra protection, but to actually keep my N95 mask clean and avoid any sort of moisture or hand sort of grease get on the N95, so I can actually continue to recycle the N95 mask for a long period of time. And so, I mean, I did this for 2 months, and it was fine. Yeah.
And Dr. Cherry, didn't we utilize maybe, like, it seems like we were using, was it paper sacks that we were put in the mask in the paper sack, you know, for each day of the week, and then just kind of rotating those as well for some of our nursing staff for the productions?
Correct. You know, and just like what Kabir was saying, you know, there's been some good studies about the COVID-19 virus, how how viable it is after a certain time period. And it was some of the studies we've utilized with some of our industrial hygienists for our clients. They were wanting to know specifically, you know, for glass, for porous surfaces, but it looks like the half-life is really, you know, between half a day to a day. So once you hit 4 or 5 half-lives, you essentially have statistically no virus left. And so really, you know, 5 days or so is probably quite protective. And then, you know, Kabir's put a classic industrial hygiene measure of a safety factor of 2, which is very common. So for all the toxicology studies, they get to a certain level and they say, okay, let's half it again, you know. So but yeah, it's you know, I think I would get a lot of questions from friends and family about Amazon packages. And so I said, you know, eventually you're going to run out of Lysol or some other type of cleanser. So just let them sit for a day. If you, depends how expensive, I guess, your packages are and how much you trust them being outside. But, you know, time, and I believe too, you told me, Kabir, that you would use them, kind of maybe hang them from your rearview mirror to get some ultraviolet light too.
Yeah, I mean, exactly. I essentially, and you see everyone doing it. If you pay attention to their cars, they're hanging their masks on their rearview mirror. So I think that, like, that's probably protective, you know, as long as you don't use that mask. I mean, if you're out in the community, that's the best way to actually, that's the best place to keep your mask, in my opinion. But if you're going in and dealing with COVID patients like I am, you know, at the end of the day, I kind of don't want it to be hanging there just because you turn on the AC and then there's probably you know, part of, if there is any virus on that mask, it's going to be spraying into my face. And so I actually just put it in the trunk of the car. But for the average person, I do have a mask that I hang on my rearview mirror, and that's the mask that I use to go to the grocery store or anywhere else.
Okay.
You know, where it's like very low risk in general.
Yeah, good ideas. I love that. All right, let's see. Roy is asking if there was a general consensus as to whether or not employees should be tested for COVID-19 before returning to work. So I'm assuming that this would be for someone that maybe had displayed symptoms that was there.
You know, so the CDC has provided specific guidance, and this has evolved since the beginning. Obviously, I think there's I'm not sure who said this, but I love it. It's science is becoming less wrong over time. And, you know, so this guidance has really evolved over time. Originally, there was only a symptomatic approach to case or management of symptoms, isolation, and then return to work. And so, you know, I think originally it was kind of like the old flu guidance of 24 hours once symptoms resolved, you could return to work. But that quickly changed to 7 days, and now it's 10 days. And then as testing became available, there was a testing strategy of 2 negative tests 24 hours apart. And then over time, that's become less preferred by CDC. They still have it in their literature or their documentation. But essentially, if someone is even a presumed COVID case or a confirmed COVID case, there's studies that show really essentially that no one is contagious after day 9. So, or after day 9. So return to work at day 10. You know, in the occupational realm where we're supporting corporate clients, we may do more of an active surveillance approach, which was kind of the approach Kabir talked about in his hospital setting, where everyone would get a test just because you wanted to know it would guide other behavior. So I think for the individual who's not in a safety sensitive or critical infrastructure job, you know, really the guidance is if you're symptomatic to get tested. We have very what I would call special populations where they have active surveillance 3 times a week, depending on the nature of their role or just specific requirements by their regulatory bodies. And so I think it depends in this specific question. If none of those, if this person doesn't belong to a special population, then you could, they call it discontinuation of social isolation at 10 days. But again, if you have any critical nature of your job, I know specifically the vulnerable populations come to mind. So if you work at a nursing facility, I would suspect they would have a kind of a testing protocol needed to return to work, or for any other high-risk groups. So, you know, that's been my experience on that matter.
Okay, great. Let's see. The next one came from Julie and was asking, I don't think we've ever had this one be asked before, but this was, do you have any concerns about having a flu shot if you've had COVID-19? You know,
I don't think there's any contraindications. You know, you don't want to get any vaccines while you're ill. But once you're, you know, not ill any longer, you know, then there's really no contraindications to get your flu shot. So that's kind of in the back of my mind. I don't know if you have any additional guidance, Kabir.
Yeah, I agree. I think that if you've recovered, then I would say that it's okay to get the vaccine. It's actually important.
Right. Yeah. And you bring up a really good point right there, is that, you know, the importance of actually getting these vaccines. What type of an impact will that make by actually going ahead and getting your flu vaccine?
Well, it's just, I think if you look at the national statistics or international statistics, like vaccines make a huge impact when it comes to infection and illness. And I think that it goes beyond, because, you know, spreading the virus itself is also a concern. And so if you are a healthy individual who may not want to get vaccinated, that, and let's say you choose not to and you contract the virus, let's say it's only 50% effective. So out of 100 people, 50% of them are going to get infected. That's still 50, but when you're looking at like hundreds of millions, if not billions of people on Earth, I mean, these numbers are actually going to be significant. And if you are a healthy individual, the individual next to you who may be either immunocompromised or elderly, that can have a huge impact on their outcome. And so I think that when you look at like population health, and I think, you know, Scott can really speak of this, you know, vaccines make a huge impact when it comes to public health.
Sure.
Yeah, I can just add a little bit. I think we've become quite complacent with vaccines, especially in first world countries. What really opened my eyes was military medicine, where we would go to third world countries that may be naive to measles. And even me as a doc, I did not realize how deadly like a measles outbreak would be. And so essentially in a population that has no immunity to measles, especially amongst children, up to 50% of the children would be would succumb to measles virus. They would die. And so I think here in the US, we don't realize, like, we don't even really think about measles. I might have heard of some outbreaks of measles, maybe just because there's pockets of the country that aren't doing that vaccination, but it's a very impactful tool on a case-by-case basis. And then, you know, the population health approach, you know, I think flu utilization hasn't been where we would like it to be, but now with COVID being a confounder with regard to influenza-like illness in these time periods, if you're inoculated to flu, then it helps kind of give us some insight that it's maybe more likely than not COVID. And I just think it's, you know, the risk reward is quite high. You know, for instance, when I was in the hospital doing occupational medicine for hepatitis B, for surgeons or technicians in the operating room that had their hepatitis B vaccination, if they got a needle stick with a hepatitis B patient, they essentially had no risk of getting hepatitis B. However, if that healthcare worker wasn't inoculated, then they had a large risk. And so from a primary prevention perspective, it's very, very powerful. Great. You know, and I think for, you know, COVID and flu, that efficacy is probably not near 100%, but it'll be interesting to see once COVID vaccines are released to see how efficacious they are.
Right, absolutely. All right, let's see. We've got, I think, 2 more questions. Next one was from Wayne that was asking, based on your experience, are the new 15-minute quick COVID-19 tests accurate?
You know, accuracy has been an interesting topic. Right now, all of the tests that are released in the US are under an emergency use act by the FDA. So the FDA regulates all diagnostic tests. And usually there's a fairly lengthy period that requires a significant amount of experience and data with a test to show, you know, its positive predictive value, its negative predictive value, sensitivity, specificity. But all of the COVID tests are kind of under this preliminary emergency use act. So all of the data supporting them is limited, but there's still a baseline criteria for which to get that emergency use act. So in general, there are probably some tests that have higher efficacies than others, but if they have a genuine emergency use act authorization, I feel relatively comfortable. We do work with specific clients if they're looking for the highest efficacy test, if possible. I believe the 15-minute quick tests are slightly less sensitive than the the original PCR test that takes about 1 to several days, depending on how busy the lab is. But it's my estimation that the data is so new or immature that essentially they're equivocal. But that's my opinion. Kabir may have a different perspective on this.
Yeah, I mean, we just do PCR only.
Okay.
So just because it's a higher quality test.
Yeah. But, it does look like that, and we've seen this and that have implemented these approaches, but just to the importance of actually having that comprehensive layered approach where they would maybe be able to use some of these quicker tests in the beginning, but pair that with maybe like a weekly PCR test so that you still have the ability to effectively screen and have that surveillance element, but also you're not subjecting everyone to PCR test every time. Yeah. Okay, let's see. All right, the final question's from Donna, and she was asking whether a test would be the only way to differentiate between flu and COVID-19.
I defer to Kabir for that one.
Yeah, it's the only way.
Okay.
Yeah. Easy.
Yeah. And just to kind of follow with that, and I think that we outlined it in the webinar, but just as a recap, you had both said that there's a lot of similarities in terms of the symptoms from COVID-19 and the flu, correct?
Right. I think there's exactly no difference in the symptoms except for, some of the uncommon symptoms which everyone clings on is the lack of taste or smell, or diarrhea. And I think that with social media, everyone has put like the magnifying glass on these 2 or 3 symptoms, but those are really the zebras. And so what's common is common, and it's going to be similar to what Dr. Cherry said, essentially fevers, chills, myalgias, cough, feeling like you're having like a flu-like symptoms.
Kabir, maybe I'd like to ask you, I saw a study that was saying that actually fever was not as a highly prevalent symptom with COVID, and probably not in the ICU that you see, but maybe just hospitalized. I think they were saying only 40% of hospitalizations had fever. Would that potentially be a way to, when you're seeing flu potentially in the hospital, is there a much higher prevalence of fever or?
I feel like, so my patient population that we're describing are those that are acutely ill that need to be hospitalized. And more often than not, they're going to have probably a multitude of symptoms, and fever is a big one. And I think that, but in the community, you may not actually see fevers or see someone with a fever. And part of it is that maybe they're having muscle aches and pains, and maybe they're taking some ibuprofen for soreness or whatever they think it is. Maybe they went to the gym, they feel very weak, tired, and sore, but the symptoms are lagging, beyond what they normally would feel. And maybe they're taking ibuprofen, so maybe they're not manifesting. So there's a lot of variables involved, but, what's common is common. So I think that having influenza-like illnesses present, in my eyes, in the emergency department, it's COVID, or influenza, but we normally treat it like COVID until proven otherwise.
Okay. Good points to follow there. Well, thank you guys so much for taking these. I know it may have felt like a marathon with so many questions, but there was a lot of good ones that came through, and they provided a lot of feedback, following the webinar. So that's excellent. We appreciate your willingness to take the time and actually meet with us on here and clear this up. Before we wrap up, any closing remarks that either one of you want to share?
I would just say that this has really been a long haul for COVID. It's new, and the danger is to kind of get complacent. We are looking at some of the infection rates, the incidents in Europe that are starting to really tick up again, and potentially here in the US too. So I know we've probably been in a slight lull the last maybe month or so, but I would really just want to reinvigorate everyone's attention on COVID and their behavioral modifications. because we want to try to be as proactive as possible during a flu season and then potentially a surge with COVID coming up. It will tremendously matter in the public, but also in your workplace and in the schools.
Absolutely.
Yeah, and I would just echo on what Dr. Cherry's saying. I think we are definitely going to see a surge. Boston and New York are already seeing a spike in numbers. So it's not if it's going to surge, it's when it's going to surge. And I know everyone's got the COVID fatigue or COVID burnout, but I'll tell you that, you know, all just common sense, cover your face, don't stay in poorly, you know, ventilated areas for too long, and just be smart when you're out there.
Mm-hmm. Yeah, you brought that point up earlier that we were discussing before we started of you know, people wearing the mask but actually not having it where they needed to be. Just would you guys just point out where it is that they need to have the mask, what they need to be covering up whenever they're utilizing the mask, just for clarification?
Yeah, I mean, it's best to have the mask covering your nose and your mouth and not used as a chin strap. So. Yeah. So covering your nose and mouth is important, because when we speak, and actually the louder you speak, the more you spread the droplet particles. And so they can go up to about 1.5 meters in distance in terms of traveling when you're speaking. And I think the same is true if you're exercising. So I think being outdoors is very important, somewhere that is well ventilated. And then maybe you can avoid even having to wear a mask altogether if you're going to be exercising. Yeah.
Okay. Well, thank you again. Just a few quick mentions before we go. Next week, Dr. Cherry and Dr. Shaw are going to be presenting on recognizing and responding to suicidal warning signs in the workplace. That's going to be on Thursday, October the 29th at 1:00 p.m. Central. So if you haven't already, please make sure that you sign up for that. And that topic is a little bit difficult to face, but having that education there to know what you're looking at, and then also how it is that you can take action. You never know when you may be able to impact the lives of maybe your coworkers or employees that you have. You can send your questions to us in advance for the town hall. You send those to coronavirus@axiomllc.com. And if you'd like to remain anonymous, we can, you know, make sure and accommodate that as well. Just not include your name with the question that's submitted. But you're welcome to download a free copy of the risk stratification of COVID-19 white paper. That's there on our website. It really speaks to the behavioral factors and assessing what those behavioral factors are for risk with your employee groups. So that's a great one. As always, if you have any questions about checking a work or checking a school, please reach out and we're happy to walk you through it. So thank you again. We'll see you Thursday at 1.